Support for this podcast comes from Bryn Mawr Communications. BMC produces a number of informative podcast series spanning a variety of topics in ophthalmology. Discover a new show at itube.net/podcasts.
Hello, amazing listeners. We made it to 2021. I have to admit, I was hoping it would feel not quite so much the same as 2020. We'll have to give it some time, I guess. And what better way to pass your time than to listen to the latest episode of the Mod Pod? Can't think of one, can you? The first episode of the new year is all about glaucoma. If you're not that into glaucoma, don't leave. There's every chance you listen to these articles and are still able to take away some solid tips that can be applied to your practice or processes, regardless of the disease state you're treating. If you do decide to jump ship here, be sure to come back next month. I promise we'll be done with the glaucoma talk. But right now, Michael Cymbor, Medical Director at the Glaucoma Institute and Managing Partner at Nittany Eye Associates, both in State College, Pennsylvania, and Nicole Stout, an Assistant Professor at Northeastern State University, Oklahoma College of Optometry in Tahlequah, Oklahoma, tag team the narration of their article, which takes us through the steps of what to do once you've identified a patient as a glaucoma suspect.
A 64-year-old woman comes into the office because she broke her glasses. During the course of her examination, a certain outlier identifies her as being at risk for the development of glaucoma. What is that outlier, and what are the next steps in this common patient care scenario?
An excellent definition of glaucoma suspect is found in the American Academy of Ophthalmology's Preferred Practice Guidelines for Primary Open-Angle Glaucoma Suspect. Quote, "A diagnosis for primary open-angle glaucoma suspect is established by the presence of one of the following conditions: a consistently elevated intraocular pressure, a suspicious appearing optic nerve, or abnormal visual field." Unquote. In other words, clinicians must be hyper-aware of the triad of nerve, field, and IOP. When an outlier in one or more of those areas is found, further investigation is warranted.
Identifying a patient as a glaucoma suspect and assessing his or her risk of future glaucomatous damage is a clinical judgment based on analysis of the patient's clinical findings and risk factors. Several clinical findings are considered risk factors for the development of glaucoma. Elevated IOP is the leading risk factor for the development of glaucoma and the only risk factor in which alteration is proved to reduce the risk of disease progression. Risk factors involving the status of the optic nerve include increased cup-to-disc ratio, presence of optic disc hemorrhages, thinning of retinal nerve fiber layer, and retinal nerve fiber layer defects. Other ocular findings that include one's risk of developing glaucoma include thin central corneal thickness, lower corneal hysteresis, the presence of pseudoexfoliation, and the presence of visual field defects. In addition to these clinical findings, there are several other aspects of a patient's history that include an individual's risk of developing glaucoma, including increased age, a positive family history of glaucoma, or a personal history of certain systemic medical factors, including conditions involving vasospasm, such as migraine headaches and Raynaud's syndrome, systemic hypotension, obstructive sleep apnea, diabetes, cardiovascular disease, and smoking.
The 64-year-old woman mentioned at the beginning of this article has IOPs of 24 millimeters of mercury OD and 20 millimeters of mercury OS. Her refractive error is plus 2.5 OD and plus 2.75 OS, with reduced best-corrected visual acuities secondary to visually significant nuclear sclerotic cataracts, graded NS2. Her Van Herrick angle is graded at 3 OD and OS. Her frequency doubling screening visual field is unremarkable. Cup-to-disc ratio is 0.4 by 0.5 OD and OS. The outliers in this presentation include IOP, angle, and mildly enlarged cup-to-disc ratio with vertical elongation.
The first step after identifying a patient as a glaucoma suspect is to ensure that the patient is properly educated on this finding and on its significance. Providing patients with appropriate education on the nature of their finding should help to ensure that they understand the importance of returning for follow-up care to complete both baseline testing and future follow-up testing to monitor for progression. It is important to stress the seriousness of the findings, while also emphasizing that the condition can be managed with appropriate care and follow-up exams, and thus should not be scary to the patient. A comprehensive glaucoma workup includes evaluation of IOP on several occasions at different times of the day, optic nerve evaluation with photographic and OCT documentation, visual field testing, and angle assessment.
Intraocular pressure has circadian variation, and it also fluctuates day to day. Thus, it is important to obtain multiple IOP measurements at various times of day in patients you suspect are at risk of developing glaucoma. This will give you the best picture of these patients' true IOP range. Documenting the highest IOP, or Tmax, is a helpful metric in differentiating primary open-angle glaucoma from normal tension glaucoma.
Optic nerve head assessment with fundus biomicroscopy and photos is critical. The clinician should evaluate the optic nerve size and cup-to-disc ratio with particular attention to whether the nerve obeys the isn't rule. The isn't rule states that, in normal eyes, neuroretinal rim thickness follows the pattern of inferior, superior, nasal, and temporal. The isn't rule is often disobeyed in glaucoma, and this finding should arouse suspicion. In evaluating disc size, a small amount of cupping may be significant in small discs, whereas large discs may look suspicious and still be physiologic. An increased cup-to-disc ratio, or a difference in cup-to-disc ratio of 0.2 between the eyes, should increase suspicion for glaucoma. Furthermore, the clinician should be careful to evaluate the optic nerve for disc hemorrhages and RNFL defects. Detection rates for disc hemorrhages have been found to be surprisingly low on clinical examination alone, but they are much more frequently detected on review of optic nerve photos. Patients with ocular hypertension with a disc hemorrhage more frequently develop glaucomatous visual field defects than patients with ocular hypertension without a disc hemorrhage. Glaucomatous RNFL loss can be diffuse or localized in the form of a wedge-shaped defect. Localized RNFL defects are observed in about 20% of glaucomatous eyes that are usually located in the inferior temporal and superior temporal regions. Localized RNFL defects are often easier to uncover in early glaucoma because defects often widen as the disease worsens. The use of a red-free filter can enhance one's ability to pick up RNFL defects.
OCT is an excellent tool for evaluating risk in a glaucoma suspect. Most OCT instruments can evaluate both the RNFL and ganglion cell layer and compare patients to a normative database. Most instruments will divide the RNFL and ganglion cell layer into sectors and assign a green color to sectors that fall into the category of 5 to 100% of age-matched controls, yellow for 1 to 5%, and red for less than 1%. Care must be taken in dealing with high myopes or high hyperopes, as most databases do not include these patients. Patients with an RNFL thickness of less than 79 microns, or a between-eye difference of more than 9 microns, must be evaluated closely. Regarding ganglion cell layer analysis, a between-eye asymmetry of greater than 5 microns, or an asymmetric pattern across the temporal horizontal raphe must be investigated further.
Evaluating visual function with standard automated perimetry is helpful for detecting visual field loss and for monitoring the rate of visual field change over time. Visual field testing may be unremarkable in early glaucoma. A study by Wolstein found that RNFL loss of approximately 25% in the superior and inferior quadrants is necessary for a detectable visual field defect to occur. One of the most commonly performed visual field tests is the Humphrey 24-2 visual field, which tests 54 points, each 6 degrees apart, in the central 24 degrees, except for nasally, where it extends to 30 degrees. The downfall of this test pattern is that it tests only 12 points within the central 10 degrees of the visual field and thus lacks detailed information from this area. This means that glaucoma suspects presenting with initial parafoveal scotomas may not be detected with this test pattern. It is for this reason that the 10-2 visual field pattern, which tests 68 points, each 2 degrees apart in the central 10 degrees, is a good option in addition to the standard 24-2 visual field pattern in monitoring patients for glaucoma conversion.
Assessing the anatomy of the anterior chamber angle is required as part of the evaluation of glaucoma suspects in order to determine whether the angle is open or closed, and to rule out the presence of secondary causes of glaucoma. Assessing the anatomy of the anterior chamber angle with at least one subjective method, such as gonioscopy, and one objective method, such as OCT angle, Scheimpflug imaging, or B-scan, is recommended.
Once all baseline testing has been performed, a diagnosis of glaucoma may be made by the clinician, provided enough evidence exists and treatment started. If not enough evidence exists, monitoring the patient for change over time is a reasonable option. If progressive changes to the optic disc, nerve fiber layer, or visual field are seen subsequently, a diagnosis of glaucoma can then be made and treatment begun. The primary goal of therapy is to slow visual deterioration so that the patient experiences no symptoms from the disease during his or her lifetime. Treatment for glaucoma involves lowering IOP by either pharmacologic means, laser, or surgery. Historically, IOP-lowering drops have been the first-line treatment for primary open-angle glaucoma and ocular hypertension. However, it is now common practice to offer selective laser trabeculoplasty as a first-line treatment in patients with early to moderate stages of disease. There are several advantages to choosing SLT as first-line treatment. It removes the barrier of topical therapy cost and eliminates issue with topical therapy compliance and with adverse reactions to long-term topical therapy, such as worsening of ocular surface disease. The decision to initiate treatment should take into account factors other than just clinical findings. The patient's mental status and level of comprehension of the disease process and treatment recommendations, the patient's overall health and life expectancy, the risk of side effects of treatment, and the financial burden associated with the recommended treatment are all worth consideration. It is also important to include the patient in the decision-making process regarding when to initiate treatment, particularly in the event that the decision to treat is not clear-cut.
In our patient's case, we elected to monitor her after establishing baseline values with testing. After several visits, we determined that her Tmax was 26 millimeters of mercury OD and 23 millimeters of mercury OS. Average IOPs were in the low to mid-20s OD and low to mid-teens OS. Her OCT showed progression of the supratemporal RNFL in the right eye from a baseline thickness of 102 microns to 85 microns after several visits. The T-SNP graph on OCT also showed change in the supratemporal sector in the right eye. Similar findings were seen in the left eye. Gonioscopy revealed scleral spur in all quadrants. We made a diagnosis of primary open-angle glaucoma, but noted that, although the angles were narrow, there was no iridotrabecular contact. With this diagnosis in hand, and after discussion with the patient, we elected for cataract surgery plus goniotomy with the Cahook dual blade due to her visually significant cataracts and narrowing angle.
There are many factors that increase one's risk of developing glaucoma. It is our role as optometrists to identify when these risk factors are present in our patients and then to perform the appropriate clinical testing to assess the severity of risk, low, moderate, or high. After initial risk assessment and baseline testing, follow-up testing must be performed to monitor for progressive glaucomatous changes over time. This process is usually not completed in a single office visit, which is why proper patient education regarding the nature of the condition is so important. Your patients must be informed of the severity of their condition, the treatment options, including your treatment recommendations, and the risks associated with not treating the condition, including the risk of permanent vision loss. When your patients understand their disease state and their treatment options, they are best equipped to make informed decisions in the management of their glaucoma, and they will be more inclined to comply with a mutually agreed upon treatment or management plan.
Clearly, testing, education, and follow-up are vital once a glaucoma suspect has been identified. What did you think of this article? Email us at modernod@bmctoday.com to let us know. Next, we'll hear from Paul Hammond, a consultative medical optometrist at North Suburban Eye Specialist in Coon Rapids, Minnesota. He's going to give a rundown of the latest trends in glaucoma diagnosis and treatment.
From Hans Goldmann's invention of the bull perimeter in 1945, to his development of the applanation tonometer in 1950, to the introduction of timolol maleate in 1978, clinicians and scientists have taken meaningful steps forward over the decades towards halting vision loss from glaucoma. Now looking forward into 2021, the foundation is set for even better diagnostics, more effective pharmaceutical treatments, and safer procedures to allow us to intervene sooner in the disease process, potentially preserving more of our patients' vision and quality of life. Let's take a look at some of what's new and what's to come. Goldmann applanation tonometry is the mainstay of glaucoma monitoring, as IOP remains the central, modifiable risk factor to reduce the effects of glaucoma. For going on 70 years, measurement with GAT has been the standard, but the CATS tonometer prism now shows promise for measuring a more accurate true IOP. The CATS tonometer slides into an existing Goldmann apparatus and looks similar to the familiar device, the difference being the sinusoidal curved applanation surface that comes into contact with the cornea. This geometry optimizes syntration and minimizes confounding factors such as corneal thickness, hysteresis, and tear film interaction. The results of multi-center randomized controlled trials have been promising, showing improved accuracy in direct comparison to Goldmann and to intracameral pressure as measured by transducer. For objective assessment of the optic nerve tissue, OCT measurements of the circumpapillary retinal nerve fiber layer and macular ganglion cell complex have been the gold standard of the past decade. A new measurement of the neuroretinal rim, called the Bruch's membrane opening minimum rim width, is now being studied as a method of identifying glaucoma. This measurement is taken at the optic nerve, measuring the distance from the opening of Bruch's membrane to the internal limiting membrane. Bruch's membrane opening is a stable reference point, and a change in the minimum rim width over time has shown a stronger association with visual field sensitivity and glaucoma discrimination than RNFL thickness in some studies. In particular, when high myopia, epiretinal membrane, or other macular pathologies are present, Bruch's membrane opening minimum rim width may be particularly useful. Until we know more, it is likely best to use all three measurements, RNFL, macular GCC, and now the optic nerve head, for the most accurate diagnosis of early glaucoma damage for those who have the capability. The Bruch's membrane opening minimum rim width measurement is available on Spectralis OCT instruments. The main reason to treat glaucoma is to prevent functional vision loss, and the all-important visual field exam is our principal method of monitoring function. The ideal perimetry test is fast, accurate, and highly repeatable, and patients and clinicians alike long for improved options. Cue the 24-2C CETA Faster, a test protocol that is approximately 20% shorter in duration than the 24-2 CETA Fast, and at the same time adds 10 central points to the 24-2 pattern for better detection of central scotomas. These improvements do come with a trade-off, including no false negative checks and no blind spot catch trials, so a compliant and attentive patient is needed to obtain optimal results. That said, studies have shown CETA Faster's diagnostic performance to be non-inferior to that of CETA Standard and CETA Fast testing. First-line treatments for glaucoma have traditionally included topical medications and laser trabeculoplasty in theory. In practice, however, a recent survey found considerable reluctance to use SLT as a first treatment option. The LIGHT trial reaffirmed the safety, efficacy, and cost-effectiveness of SLT as a first-line therapy, demonstrating a higher percentage of patients achieving target IOP and fewer patients requiring subsequent glaucoma surgery with SLT than with medical treatment over a 3-year follow-up period. In my glaucoma clinic, I routinely offer SLT and eye drops as options for primary treatment. I outline the pros and cons of each, and usually the patient is the decider. Motivating factors appear to be convenience and the avoidance of prostaglandin periorbitopathy and ocular surface issues, especially in young and active patients. Excellent results can be achieved with 360-degree treatment in mildly to moderately pigmented trabecular meshwork. However, 180-degree treatment is prudent in patients who have pigmentary dispersion syndrome to limit the possibility of a transient spike in IOP. It is important to discuss the duration of SLT effect with patients, as it is a useful treatment but not a cure. I tell patients that it works well for about 75% of those who choose this option, and that the effects last 2 to 4 years. Regular follow-up and testing are necessary regardless of the patient's treatment choice. When IOP remains above target despite treatment with a prostaglandin analog, additional medical therapies are often the answer. Adjunctive drugs have traditionally required multiple daily dosing and can have a detrimental effect on ocular perfusion pressure. A relatively new once-daily alternative is notardicil and latanoprost ophthalmic solution. This fixed combination drop includes a novel Rho kinase inhibitor targeting the traditional outflow pathway of the trabecular meshwork. In the Mercury 2 trial, more than twice as many patients treated with notardicil latanoprost achieved at least a 30% reduction in IOP compared with those treated with latanoprost alone. The complementary mechanisms of targeting both the trabecular meshwork and the uveoscleral pathway with once-daily dosing make this an ideal medication to substitute when the latanoprost alone is insufficient, and it also pairs well with an aqueous suppressant fixed combination for maximum non-surgical IOP control. The most common side effect to prepare patients for is mild hyperemia. When patients are notified that this may happen ahead of time, it is less likely to be an issue, and when discussed in the context of possible vision loss and surgery, patients are often grateful for an easy solution. When laser and topical therapies fail, surgery is indicated. Historically, this would have been by means of a high-risk, high-reward bleb-based surgery, an option that may be excessive when only modest IOP lowering is needed. In recent years, several less invasive surgical options, grouped under the heading of micro-invasive glaucoma surgery, or MIGS, have emerged. Examples include the iStent inject, the Hydrus microstent, and the newest to the scene in the United States, the angle-based Omni surgical system. The Omni is a viscodilation and trabeculotomy procedure that maintains a better safety profile than bleb-based procedures. The Omni surgical system's FDA clearance allows for it to be used in combination with cataract surgery or as a standalone procedure. The other procedures are indicated for use only in combination with cataract surgery. Postoperative hyphema and steroid response with the Omni are generally mild and transient. Mild peripheral anterior synechia formation can limit IOP control in a minority of cases. In patients with a baseline medicated IOP of more than 18 millimeters of mercury, the Omni demonstrated a mean decrease of 26%, approximately 6 millimeters of mercury, and a decrease from 1.7 medications to 1.2 at month 12. The Omni appears to be an ideal mitigating procedure in offering excellent results, minimal relative risk of complications, and preservation of precious conjunctiva for bleb-related procedures in the future if necessary. The journey to curing glaucoma is long, but we are gaining speed. With new technologies, safer treatments, and continued ingenuity, our patients will be the better for it.
We were just talking about developments in the treatment and management of glaucoma, and we're about to hear Aaron McNulty, an optometrist at the Louisville Eye Center in Kentucky. His article discusses the changing role of laser in the management of patients with open-angle glaucoma.
Support for this podcast comes from Bryn Mawr Communications. BMC produces a number of informative podcast series spanning a variety of topics in ophthalmology. Discover a new show at itube.net/podcasts.
Historically, laser trabeculoplasty was second-line therapy for primary open-angle glaucoma. Topical medications were the unquestioned first line. If maximum tolerated medication failed to yield adequate IOP reduction, argon laser trabeculoplasty was a useful middle step before the more drastic decision to proceed to incisional surgery. This landscape has changed over the past 20 years. What does the latest literature tell us about the current role of selective laser trabeculoplasty in the management of POAG, and how should we be incorporating this management option in optometric practice? Let's explore the answers to these questions. We practice in a golden age of topical glaucoma therapy. Today's anti-glaucoma medications are wonderfully effective with tolerable side effects. There's no shortage of options for first-line or adjunctive drops. However, topical glaucoma medications are not without problems. First, we know from personal experience that patient compliance is not optimal. The literature tells us that it is likely even worse than we suspect. Studies using health insurance claims data suggest that compliance decreases as dose frequency increases. Compliance also suffers as time passes from the initiation of therapy. Even our most compliant patients inevitably miss an occasional drop. Actual or perceived side effects complicate the compliance issue. Second, diurnal control of IOP is another classic concern in the management of glaucoma. Although today's glaucoma medications yield relatively good 24-hour control, a flat diurnal curve remains an elusive target for the glaucoma clinician. The literature demonstrates that SLT can blunt nocturnal spikes in IOP even for patients who are on multiple medications. Finally, we find ourselves spending increasing time and resources jumping through formulary hoops. A given patient may be restricted to relatively few choices of topical medications on his or her formulary. If a physician's preferred medication is excluded, acquiring it may be cost prohibitive for the patient. Further, going through the steps of step therapy can be burdensome for the practice from a clinical and logistical perspective. And when step therapy limits us to prescribing generic medications, we may have concerns about variable results in IOP control and tolerability. Modern ALT was born at the end of the 1970s. SLT was introduced by Latina and Park in 1995. The first device for this procedure received FDA approval in 2001. The mechanism of action of SLT remains controversial, but it is thought to depend on a biological response to targeted inflammation. Laser energy targets intracellular melanin in the trabecular meshwork. The targeted cells activate cytokines, which activate macrophages. These inflammatory cells clean the area of cellular debris, decreasing outflow resistance. Unlike ALT, SLT causes no mechanical damage to the trabecular meshwork. A number of recent publications have challenged the traditional glaucoma paradigm of medications first, followed by laser therapy as second-line treatment. In the SLT Med study in 2012, patients newly diagnosed with POAG or ocular hypertension were randomly assigned to either SLT or a topical prostaglandin analog. The authors found no statistically significant differences in IOP reduction or need for additional treatment between the two groups. They concluded that SLT is a viable first-line treatment for patients with newly diagnosed POAG. The American Academy of Ophthalmology's preferred practice pattern for management of POAG states that laser trabeculoplasty can be considered as initial therapy in selected POAG patients. This is significant as these guidelines are generally conservative and avoid adopting controversial therapies. The American Optometric Association's clinical practice guideline for primary open-angle glaucoma was in the review process at the time of this article's writing. Up to Date is an online clinical service that catalogs studies and rates the strength of evidence. This service provides its strongest level of recommendation for the option of laser trabeculoplasty for first-line treatment of open-angle glaucoma. A 2015 meta-analysis by Oiman Wang et al. Concluded that there is robust evidence to support the use of SLT as primary treatment for POAG. In 2019, the LIGHT study evaluated SLT versus eye drops for first-line treatment of ocular hypertension and glaucoma. LIGHT was a randomized clinical trial in which more than 700 patients were followed for 3 years. Primary endpoints included quality of life, efficacy, cost, and safety. The authors found strong evidence to support the use of SLT. They found that SLT provided IOP stability superior to that achieved with drops and at a lower cost. Further, 74% of participants receiving SLT were successfully controlled without drops for at least 3 years after starting treatment. The authors also found a slightly higher rate of rapid visual field progression and more need for incisional surgery in the medication treatment group versus the SLT group. The net result of these important publications is that trabeculoplasty is gaining widespread acceptance as first-line therapy for ocular hypertension and POAG. Questions have lingered regarding the repeatability of SLT. The procedure has generally been considered repeatable, but this has been based mostly on anecdote and small studies. Recently, new entries in the literature have thrown more light on this question. A 2019 review by Guo et al. Cataloged several previous studies that addressed the repeatability of SLT. The authors concluded that the efficacy and complication rates of repeat SLT are comparable to those of primary SLT. The LIGHT authors also conducted a post hoc analysis of their study data to shed light on this issue. The authors looked at patients requiring retreatment within 18 months of primary SLT. Retreatment was triggered either by failure to reach individualized target IOP and/or disease progression. In 115 eyes that met these criteria, Kaplan-Meier survival estimates illustrated a 67% success rate for repeat SLT at 18 months after retreatment. These data were striking given that the eyes included in this post hoc analysis had demonstrated a 0% success rate 18 months after their primary SLT. The LIGHT authors concluded that repeat SLT may have a cumulative treatment effect that can provide a longer duration of clinical benefit than primary SLT alone. In states with expanded optometric scope that includes laser therapy, the implications of the finding reviewed above are clear. We should be discussing SLT with patients at our initial diagnosis and offering it when appropriate as a primary treatment option. Many patients, given the choice of instilling daily medication or undergoing an infrequent, non-invasive laser procedure, will prefer the convenience of the latter. In my practice, initial treatment discussions with patients include SLT when clinically appropriate, in most cases of POAG. Many patients opt to start with topical medications. However, we often return to the conversation about SLT with these patients months or years later. Sometimes patients find that side effects of their medication become problematic. Other times they realize that compliance is more difficult than they expected. Or perhaps insurance formulary changes make SLT a more cost-effective option. SLT should also be discussed when we change drops or add adjunctive medications. Commonly, a medication problem prompts this conversation. Perhaps we are not achieving adequate IOP reduction, or we need to change medications for some other reason. As noted above, compliance decreases with increasing medication burden, creating an opportune time to discuss SLT. If you practice in a state where optometric scope does not include laser, it is advisable to partner with a glaucoma surgeon who is willing to co-manage trabeculoplasty. Expect to re-refer patients for repeat procedures when necessary, generally every 1 to 3 years. SLT plays a prominent role in the modern management of POAG. If it does not currently have a prominent role in your glaucoma treatment paradigm, consider rethinking the utility of SLT early in the management of patients with this disease.
Clearly, the tides are shifting regarding the role of SLT in open-angle glaucoma. Is your practice keeping up? Well, we're down to the final article of the episode. Let's talk adjunctive therapy for glaucoma. Matthew Bovenzi, Assistant Clinical Professor and Assistant Chief of Primary Care at University Eye Center at the SUNY College of Optometry in New York, will read the article he co-wrote with Richard Madonna, who is Professor and Chair of the Department of Clinical Education at SUNY. The topic: when do you consider adding a second drop?
A topical medication, usually a prostaglandin analog dosed once per day, is the most common initial treatment for patients with ocular hypertension and glaucoma. Although some clinicians view the need for additional therapy as treatment failure, the need for adjunctive therapy is common and is characteristic of the progressive nature of this disease. In clinical trials, 40% or more of enrolled patients have required the use of 2 or more medications to maintain their target IOPs. When should you consider adding a second drop to a patient's treatment regimen? When determining whether to add a second drug to a patient's existing treatment regimen, you first need to ask yourself whether adjunctive therapy of any kind is needed. If the answer is yes, then the next step is to figure out which type of adjunctive therapy is best for your patient. Consideration of additional IOP-lowering therapy occurs under one of 2 conditions. The patient's IOP is not at the target pressure that you have set, or progression is detected on structural and/or functional testing. Establishment of a target pressure range is an essential but often overlooked element of initial glaucoma treatment. Target pressure is defined as the IOP at which further glaucomatous damage is unlikely to occur. Although the establishment of a target pressure is in part an educated guess by the provider, it should be based on the baseline untreated IOP, disease severity, and risk factors that increase the patient's chance of progression. Following the treatment regimens of landmark studies such as OATS and CIGITS, an appropriate starting point for target IOP might be 20% to 30% lower than baseline for patients with mild glaucoma, about 30 to 40% lower for patients with moderate glaucoma, and about 40 to 50% lower for patients with severe glaucoma. Consider patient M, a 60-year-old man of African descent whose mother had moderate glaucoma. His initial examination reveals moderate glaucomatous optic neuropathy, retinal nerve fiber layer thinning on OCT imaging, and corresponding visual field loss in each eye. His untreated IOP averaged over 3 visits is 22 millimeters of mercury in the right eye and 20 millimeters of mercury in the left. Because of the severity of his disease, his age, race, and family history, you believe that a 40% decrease in IOP is indicated, so you set your target pressure at 12 millimeters of mercury to 14 millimeters of mercury in the right eye and 11 to 13 in the left. You start Mr. M on a prostaglandin analog and monitor him. After 3 follow-up visits, his average pressure is 16 millimeters of mercury in both eyes. Adjunctive therapy should be instituted to achieve target pressure unless you feel that the higher IOP is acceptable for the patient, in which case your target IOP could be raised. In this case, however, given all the risk factors noted above, that would probably be unwise. The most important aspects of glaucomatous management include identification of structural progression, whether by disc photos or, more commonly, OCT imaging, or functional progression by analysis of sequential visual fields. Even more important is the identification of patients with rapid progression that poses a significant risk of causing loss of vision-related quality of life. Rapid progression can be defined as a reduction of greater than about 2 microns per year on global RNFL thickness or greater than 2 decibels per year on visual field mean deviation, but these are just 2 of many published guidelines. Such guidelines should always be considered in the context of the patient's age, severity of disease, location of field defect, and frequency of testing. When in the practitioner's judgment, vision-related quality of life, or VRQOL, is threatened, more aggressive treatment should be instituted, regardless of whether the patient was at his or her target IOP or not. Mrs. G is a 68-year-old white woman with moderate glaucoma. She is being treated with latanoprost ophthalmic solution 0.005% every night at bedtime OU, which has lowered her IOP from 22 mm of mercury in the right eye pre-treatment to her target IOP of between 14 and 16 mm of mercury. Recent OCTs and visual fields have both shown rapid, repeatable progression. It was felt that the rapidity of progression and her relatively young age put her at risk for loss of VRQOL, so her target IOP was reduced to the low teens, and adjunctive therapy was instituted. The answer to this question should be individualized for every patient. Alternatives to adding a second drop include laser trabeculoplasty, microinvasive glaucoma surgery procedures, or MIGS, alone or with cataract surgery, or, in severe cases, glaucoma filtering surgery. The most propitious choice can be made when we take into account the patient's attitudes and comprehension of his or her disease, recognition of ocular and systemic risk factors, and knowledge of the severity and stability of his or her glaucoma, along with the risks and benefits of each adjunctive alternative. For example, laser trabeculoplasty and MIGS procedures reduce the need for adding a medication and eliminate the subsequent side effects and reduction in therapy adherence associated with adding a second drop. That said, many patients may fear laser and surgical procedures and prefer adding a second topical medication to undergoing a more invasive procedure. After determining that a medication is the best option for your patient, you must then decide which to use. As with all decisions in glaucoma management, this should be individualized for each patient. There may be times when adjunctive medicine can be avoided and the once-per-day regimen preserved by switching drugs within the prostaglandin class, switching to a prostaglandin with a dual mechanism of action, or switching to a prostaglandin Rho kinase or ROC inhibitor fixed combination. Any of these combinations may provide increased IOP lowering. Adjunctive therapy outside the category of prostaglandin analog can be single medications or fixed combination drops. Single medications include beta blockers, alpha-2 agonists, carbonic anhydrase inhibitors or CAIs, and ROC inhibitors. Fixed combinations contain 2 medications in one bottle. One advantage of adjunctive therapy with a single agent is the knowledge that IOP reduction or side effects are most likely due to the new medication. Generally, the IOP lowering effects of any of these agents added to a prostaglandin analog are similar. The chief differences between them are their side effects, dosing, cost to the patient, generic availability, nighttime efficacy, and mechanism of IOP lowering. Each of these factors should be examined in every case. In the past few years, use of fixed combination medications has greatly increased. In the United States, combinations of beta blockers with CAIs or alpha agonists and CAIs, and most recently, a ROC inhibitor with a prostaglandin analog are available. Fixed combinations are indicated when a patient is already taking 2 drops and needs further IOP lowering, or when it is felt that adding a single agent will not lower the IOP adequately. Fixed combinations reduce the number of instillations, reduce drop washout, and provide excellent IOP lowering. Recently, many practitioners have gone directly to fixed combinations rather than the step-by-step addition of single medications because of the excellent IOP lowering of the combination and the fact that the side effects of the individual components are well known. Cost can be a drawback, although generic formulations are available in some cases. Importantly, the use of multiple drops can result in ocular surface disease due to the toxicity of the preservatives, chiefly benzalkonium chloride or BAK, used in some medications. Although this can be managed with non-preserved artificial tears and other dry eye therapies, preservative-free versions of timolol and of dorzolamide HCl and timolol maleate ophthalmic solution are available. Additionally, the patient's prostaglandin could be switched to a preservative-free alternative or one with a milder preservative. The decision to add a medication to the treatment regimen of a patient with glaucoma or ocular hypertension should be based on the patient's disease staging, risk or evidence of progression, and ability to adhere to adjunctive therapy. Side effects, contraindications, cost, and dosing schedule are all considerations in choosing an appropriate single-use or combination medication. If adjunctive therapy with medication is not enough or not appropriate for a given patient, whether due to compliance, cost, or other reasons, options such as laser trabeculoplasty, cataract surgery with a MIGS procedure, or filtration surgery should be explored.
That was a great article packed with a lot of information. If you're more of a visual person, check out the article online at modernod.com. There's a nice decision tree for when to add a second drop. Thanks so much for finding your way back to the Mod Pod. Be sure to tell your friends and colleagues about this podcast. Listen and subscribe for free on iTunes, Spotify, Apple Podcasts. You know where to go and what to do. Have an article idea? Type it up and send it over to us at kroman@bmctoday.com. That does it for us this time. We hope you'll join us back here next month.